what I have the honor to present is on behalf of my co-investigators. It's an international trial which opened in 83 sites across 16 countries around the world. It's the pivotal trial that is aimed at changing how we treat patients with advanced melanoma, melanoma being the most aggressive of skin cancers. That we go back, Susan and I have been, can go back on melanoma. I can tell you that not that long ago, we would be in front of patients and we would be talking about treatments that may help 1 in 10 patients and most of them were temporary effects. But this has changed in the last few years with the development of new agents, in particular the agents that turn on the immune system. For the last 100 years, our field has tried to turn on the immune system to fight the cancer. But it didn't work well. Anecdotally, somebody did well, and then majority of patients, it didn't work. Jim Allison, who was at Berkeley around 20 years ago, came up with the paradigm-shifting idea that instead of trying to turn on the immune system to cancer, what we had to do is take away a brake. Because the immune system may have been primed to attack the cancer, but our immune system tries to stop immune responses to self because it's designed to fight virus and bacteria, not fight cancer. So we need to trick it in some way. So the first way to trick it was to use an antibody that blocks CTLA-4, which is, I'm trying to see if I can have a pointer, well, it's okay. An antibody to CTLA-4 which blocks an early step on activation of the immune system. And that's what led to the development of Ipilimumab that's been branded as Yervoy, and it's a standard of care of patients for melanoma because it improved survival in 2 randomized trials. It's actually the first agent ever to improve survival in patients with melanoma. So this has become the standard of care of patients. But once the immune system is activated, even when we release CTLA-4 with Ipilimumab, and that immune system goes into the tumor, then the tumor has another way to escape the immune system, which is the PD-1 brake. And I should maybe go down, but I cannot point. It's on the right side of that slide, where the immune system cell called the T cell tries to attack the tumor. The tumor protects itself from this PD-1. What we want to do is unleash this, and that's something that Dr. Topalian first did in clinical trials, and this is following on her work to develop a study that would compare these 2 approaches. So Pembrolizumab, which is the drug that Eddie Garon and I are going to be talking about, is a humanized IgG4 antibody that blocks PD-1, and by doing that, releases this late brake to the immune system. So we compared the 2 approaches, the one that's a standard of care and the new way of doing this. This study enrolled 834 patients across 83 sites in 16 countries. Patients were randomly allocated to 2 dosing regimens of Pembrolizumab. This program has gone so fast from treating the first patients to where we are that we didn't know what was the best dosing regimen going on to this pivotal trial. Oh, by the way, Pembrolizumab is branded as Keytruda after it was approved by the FDA in September for the treatment of patients who have progressed on Ipilimumab. So here, instead of progression on Ipilimumab, it's compared head-to-head with Ipilimumab or Yervoy. So this is the allocation of patients, 3 arms, very clean study. And the primary endpoint, there were 2 interim analyses that we're reporting on. The first interim analysis, the primary endpoint of the study is progression-free survival. Progression-free survival means the time until patients progress on therapy. The Pembrolizumab arms are in red on the top with one of the dosing regimens. Green is the other dosing regimen, and the control, Ipilimumab or Yervoy, is the purple line. The curves, starting from the left, separate initially, and then they get close at the 3-month time point, because that's when we had the first scheduled scan, taking of scans. So that's when the majority of progressions would be detected. And thereafter, they separate. The median follow-up in this time was 8 months. So anything beyond 8 months is not reliable part of the curve. And you can see on the bottom, there's the patients at risk, there's very few of them. So you can kind of plan until 8 months. The best numbers to quote is the rate of progression-free survival at 6 months because of this effect of the curves coming together and then separated. But 6 months, we see that it close to doubles the progression-free survival with pembrolizumab over ipilimumab. The hazard ratio, which looks at all of the curve, tells us that being on pembrolizumab decreases the risk of progression by 42%. That's the hazard ratio of 0.58. And the p-value has a whole bunch of zeros, so it's highly statistically significant. This is the most important endpoint, overall survival. This is taking all of the patients, what happens to them, being followed up every 3 months, regardless even if they went off therapy or continued on therapy. So the curve has the same color coding. In red and in green, the two arms of pembrolizumab, the two different dosing regimens. There's basically no difference between them. And then the purple is the ipilimumab curve. This study is overperforming all of our expectations. Even the ipilimumab arm is doing much better than is expected. The follow-up is 14 months here, and the ipilimumab arm has not reached the median survival. The historical data is that ipilimumab had a median survival between 9 and 10 months. So even the control arm is doing better because there's a whole bunch of other therapies that those patients can get afterwards. But the pembrolizumab arms are clearly on top. The overall survival at 12 months is 74% with one and 68% with the other, compared to 58% with ipilimumab. The hazard ratio is 0.63 and 0.69, so that's between a 30 and 35% improvement in a decrease in risk of death. The p-values are highly positive. I think there's an error in this slide with the p-values. If you look at the press release from AACR, the p-values are correct there. So I don't know if you report p-values, but I see that there's an error here that should be corrected. It's let me go back. Can we go? So every 2 weeks versus ipilimumab is 0.00053, and on the bottom is 0.00358. And I remember well because I have to present it afterwards. And I don't usually remember p-values like these. So the response or shrinkage of the tumor is also better with the pembrolizumab arm. So if you look at the top line, I'm having trouble with this clicker, it's around 33% objective responses. And these responses is not me looking at scans, is sending the scans to radiologists somewhere else and them reading them and telling us what happened. So that's a 33% response rate. So a third of the patients have objective tumor shrinkage and with confirmation. With ipilimumab is 12% or 11.9%. The toxicity is also in favor of pembrolizumab. Pembrolizumab has less side effects than ipilimumab. Even though we expose the patients a lot longer to pembrolizumab, pembrolizumab is given continuously every 2 or 3 weeks for 2 years. Pembrolizumab is given just for 4 doses initially. That's how the yearly dosing regimen has been approved by the FDA. If you look at the line that says grade 3 to 4 toxicities, ipilimumab, the grade 3 to 4 toxicities are close to 20%, it's 19.9%. With pembrolizumab, the same level of toxicities is 10 to 13%. So what we conclude from this study is that the pembrolizumab is superior to ipilimumab on all of the scientific endpoints we had set up to test prospectively. It improves overall survival between 31 and 37%. It improves the time to progression by 1.8-fold, and it improves the responses, that's the ORR, it means objective response rate, by 2.8-fold. It does it by having a better safety profile. The 2 dosing regimens that we tested, there's no real evidence that one is better than the other. And then we think that this data should change the paradigm of treatment for these patients, and the standard of care should quickly shift to giving a PD-1 antibody. We're talking about Pembrolizumab or Keytruda, but the data with the Bristol-Myers Nivolumab or Opdivo should be upcoming also, and I'm pretty sure it's going to be more or less the same. So thank you.
Thank you, Tony. Thank you. So to put this in context, then Ipilimumab was approved as a first-line therapy for patients with advanced melanoma in 2011. And that was a landmark moment not only for melanoma, because it was the first drug ever to show a survival advantage in a randomized trial in melanoma, but it was also a landmark moment for immunotherapy and checkpoint blockade. So this was the first checkpoint blocking drug to show an impact on survival. And so Ipilimumab then became the gold standard against which everything else had to be measured. What you heard today from Dr. Ribas is the first demonstration in a prospectively randomized trial that another checkpoint blocking drug, anti-PD-1 Pembrolizumab, is superior to Ipilimumab in terms of overall survival, response rate, and progression-free survival. This is now expected to change the treatment landscape for melanoma. This is a very high-impact trial. So, Tony, I would like to start off with the first question, then we'll open it up to questions from the audience. I think you've demonstrated very nicely for Pembrolizumab that there is a more beneficial risk-benefit ratio for this drug compared to Ipi. Could you just summarize for us the quality of the responses? Because just going beyond response rate, numerical response rate, and median overall survivals, what is your impression about the durability of responses with anti-PD-1 versus Ipilimumab, and the number of patients who have complete tumor regressions with those two drugs?
Yes, I've been treating melanoma for 15 years, and now it's the first time that I reproducibly see patients with durable responses, and the majority of them is achieved with no side effects. We've both seen patients that had progressed on other therapies that were probably had weeks to live, and you give this antibody that gives no side effects and gives no hair loss, no nausea, no vomiting. You just infuse that and keep infusing it, and the immune system of that patient starts attacking the cancer specifically. There's no better personalized therapy than this. It works because there were pre-existing immune cells that were ready to go and were turned off by PD-1. And when that happens, those patients are doing great. The rate of responses and the rapidity of the responses and the durability, it's all impressive. And compared to Ipilimumab, with Ipilimumab, we've had responses. So I have a patient, I'm following the first patient who responded on Ipilimumab. She was treated in 2001. And at that time, she had progressed on all of the best therapies that were available at that time. That's 14 years ago. She got lung and liver metastases. She continues to do well. She's a grandmother. She comes once a year, and we just talk about her grandkids. I don't talk about melanoma anymore. Mm-hmm. But that was 1 in 10 patients. Now we have 1 in 3 patients that have these kind of things. And my perception is that patients with more aggressive melanoma are responding to Pembrolizumab, to PD-1 blockade than we ever saw with Ipilimumab.
Okay, we're now going to open this up to the news media. Please raise your hand, and microphones will come to you. Just identify who you are and your outlet, and ask your question, please.
Excuse me, Charles Bankhead, MedPage Today. What is the current approved dosage for this? Because you studied 2 different regimens.
Yeah. So actually, this clinical trial did not test the approved dose regimen for Keytruda, which is 2 milligram per kilogram every 3 weeks. It tested 10 milligram per kilogram every 2 or 3 weeks. At the phase 1 program, which enrolled over 600 patients with melanoma, and as Dr. Garon will tell you, enrolled other 600 or 700 with lung cancer. It went through with these 3 dosing regimens. in the totality of the data, there's no evidence that one dosing regimen is superior to the others. So when the data was brought to the FDA, the lower dosing regimen was chosen, which makes sense. But all of the randomized trials that have been done do not suggest that one is better than the other. And it makes sense to me. The problem is, does that patient have an immune system that's ready to go turned off by PD-1? And if the dosing regimen will not change that. If it's there, you can unleash it. If it's not there, you cannot unleash it.
Next question right over here. Oh, go ahead.
Bob Carlson, Oncology Times. What would you combine? What other treatments would you combine these checkpoint inhibitors with?
Oh, that's what we'll be talking about the next several years. And I think this is just the start. This is amazing that single agent checkpoint blockade gives these responses in melanoma, as you'll see in lung cancer. But the reality is that there's 2/3 of the patients who do not respond, and we have to do something about them. And we're studying why is that and what we should combine. And we're combining with a series of other immunotherapy drugs, with traditional therapies like radiation therapy, with injectables, with targeted therapies. I have a bias against combining with chemotherapy because I think they may not match well. Chemotherapy may kill activated immune cells, but that's just my bias.
Okay. Have you seen any evidence of resistance to the checkpoint inhibitors?
Yeah, so the more common resistance is the patients who don't respond up front. That's resistance. That's probably because their immune system was not primed to attack the tumor. We've seen occasionally a patient that has an escape lesions, and occasionally patients who progress after a period of response. But that's a minority of patients. I would give a 5 to 10% rate at that. The 80 to 90% of the responses, once they have achieved in all of the series, continue to go on, at least in melanoma.
Do you think these immunological treatments will turn melanoma into a chronic disease?
I would go beyond that. We're very conservative when we talk to patients. The word cure, it's hard to use. But a patient who goes over 10 years from having had metastatic melanoma and has no evidence of melanoma, that's not a chronic disease. That's a person who's going on with their normal life. And we're achieving things like this with Ipilimumab, and I hope with PD-1s. Very soon we'll be able to show it.
Nick Mulcahy, Medscape. What about patients, melanoma patients that have the BRAF mutation? Are they potential patients for this drug as well?
Yes, so patients with a BRAF mutant melanoma were eligible to this study. The study allowed at least up to one prior line of therapy. So some patients who had progressed on PD-1, on BRAF inhibitors or BRAF plus MEK were eligible. The response rate, progression-free survival, and overall survival in those group of patients, the ones who had progressed on a BRAF inhibitor, was slightly lower, but it was still in favor of Pembrolizumab versus Ipilimumab. The presence or the absence of a BRAF mutation did not make a difference in any of the endpoints.
Go ahead, Alice.
Alice Goodman with the ASCO Post. Could you just speak a little bit about why you have the impression that the more aggressive melanomas are the ones that respond? And are there any clues about who doesn't respond?
Yeah, no. Yeah, I may have misspoken. So what I was trying to say is that with Pembrolizumab, we do see, I personally have seen patients that I thought would not respond to an immunotherapy responding, meaning the patients who had wildly metastatic, very aggressive melanoma. And the reason why they respond is because if we look in their we do biopsies of their tumor, there were T lymphocytes that were ready to attack. So this doesn't work by the Pembrolizumab killing the cancer. It's Pembrolizumab turning on the patient's immune system, the T cells, to kill the cancer. So they have to be in the tumor pre-existing. Once some patients with aggressive melanomas have T cells in the tumor, they were just being kept turned off by PD-1, so we just need to unleash them.
Sally Church from Biotech Strategy Blog. Dr. Ribas, did you measure the PD-L1 expression in the two arms, and were they balanced between high and low, and were there any differences with the PD-L1 expression?
Yes, so in this program there was prospective testing for PD-L1, and PD-L1 was used as a stratification factor where each arm has the same number of patients who have PD-L1 positive or negative, so there wouldn't be a bias based on that. It's done by an assay developed by Merck, which is a very sensitive assay, and the cutoff point was 1% for calling it positive. 80% of the tumors were called positive using this stratification factor. The benefit in terms of progression-free survival and response rate is exactly the same between PD-L1 positive or negative, but the overall survival, surprisingly, and we still don't understand, was not the same. The patients with PD-L1 negative did not show a skewing to doing better with pembrolizumab as opposed to ipilimumab. There's a lot less patients, it's around 20%, well, half of the 20% of the study.
We have time for about 2-3 more questions. We have to move on to the next presentation. If anybody's on the phone that wants to ask a question, hit star 1. Go ahead. Next question, Suzanne.
Suzanne Rose from Cancer Discovery. You had mentioned that the patients who were responding were those whose immune system were essentially primed and ready to go. Is there anything that can be done to prime the immune system of the 2/3 that did not respond?
Yes, and if you had a quarter of an hour more, Suzanne and I would start listing a whole bunch of things we're working on to try to do this. But yes, so as we are understanding the limitations, then we can think about what we should do to correct that. And in many cases, we have to bring these immune system cells into the tumor. And at the same time, we have to unleash PD-1 on them. We may do what Dr. Riley was going to talk about, which is give T cells to patients, adoptive cell transfer, in the patients where there's no T cells that recognize the tumor. It may be an over-optimistic thinking, but my view is that in the near future, in melanoma, the great majority of patients, all of the patients, will be treated with either single agent PD-1 or a combination that addresses their particular limitation on the interaction between the immune system and the tumor.
Okay, final question.
Lynn Peterson with Trends in Medicine. So going forward, what does this mean for actual use? When you go home and you see your next melanoma patient, do we stop using Ipilimumab? Do you combine the two? Do you do Pembrolizumab off-label for now? I mean, what do you do going home?
So the FDA approval of Keytruda is on patients who have progressed on Ipilimumab or Yervoy. But the compendia listing and Medicare already allows to use Pembrolizumab up front. So we started, even in patients on Medicare, we can give Pembrolizumab up front. The national guidelines of treatment, oncology guidelines, the NCCN guidelines, has already listed giving a PD-1 antibody up front therapy. So I think the field is going a little bit faster than the FDA approval. I would assume that with this data, the FDA will soon change the label, but there's always a lag behind. But the more important thing is, when are these agents being approved in the rest of the world? I get emails, and I'm sure Dr. Topalian gets emails from patients around the world saying, we heard about these drugs, why can't I get it? Well, they're not approved by regulatory agencies outside of the US, and with this overwhelming data. So it's I think that's where we can make the biggest impact. Oh, I have not stopped using Epi, and I will not stop using Epi. It's just that upfront therapy, a PD-1 pembrolizumab, after this data is superior to Epi. But Epi can give durable responses, and it's part of the armamentarium of treatment. The data of nivolumab plus ipilimumab combinations, we're highly anticipating seeing the randomizing data from that, and the initial study suggests that Epi combined with a PD-1 antibody increases the responses. We'll just need to know which patients need that, because the toxicity is also increased significantly.
Thank you very much, Dr. Ribas.
Thanks.